let's talk about PPE. PPE is a personal protective equipment, is a very controversial area, and basically we have two. I think it's useful to conceptualize it as a three-tiered system of PPE, of which the first two are the official two tiers, and the third tier is a less official tier that's being implemented in lots of hospitals in a variable manner. And so I'll go through those. Tier one is the precautions that you need to have for the routine care of patients with suspected COVID or possible COVID, right? So anyone that you've streamed after triage to your possibly could have COVID. So these people, you just need droplet and contact precautions. And droplet precautions, for all intents and purposes, is surgical mask and some form of eye protection, which can be some sort of goggles or face shield, either one. And then your contact precautions are your gown and gloves, and the gown should be a full cover gown with arm protection as well. And so that's your straight out droplet precautions. And we're going to talk about a bit of evidence that will hopefully give you some confidence that that is really all you need for routine care of patients with suspected COVID. So that's tier one. And then tier two, I'll talk about some exceptions to that in a second, but tier two is aerosol generating procedures. So if you think you're going to be doing aerosol generating procedure, an AGP, which I'll mention in a second what they are, then what changes is instead of droplet precautions, you become airborne precautions. And those airborne precautions are just basically that you replace your surgical mask with an N95 or P2 mask. And so otherwise, everything's exactly the same. It's the mask plus eye protection plus gowns and gloves, but nothing else changes between tier two, airborne plus contact, and tier one, which is droplet plus contact. Now, there is a slight middle ground between the two tiers, and because there have been some suggestions in different guidelines that some people who you're giving routine care for, so no aerosol generating procedures, need to have need to step up to tier two to what you would normally use for aerosol generating procedures. And those people, well, there are lots of different people that people say in different guidelines, but the two that are kind of, in the national federal guidelines and have been, I think, emulated also in our WA Health PPE guidelines, is basically if you're collecting swabs from somebody as well, you can do that in normal tier one droplet precautions. But if you're collecting swabs from somebody who's critically unwell or has symptoms suggestive of pneumonia, then they recommend that you upgrade up to airborne precautions. So you switch your surgical mask for your N95/P2 mask. And they also recommend taking swabs from the side of the patient, not from the patient. And then the next thing is if you're doing routine care for somebody who's critically unwell. So patients who are going to go to ICU, when they're in ICU, but arguably also when they're in your ED and they're critically unwell, it is recommended that you should upgrade from your droplet precautions to airborne precautions, from tier one to tier two. And the theory behind that is that critically unwell patients sometimes make a lot more virus and then disperse a lot more virus. And also they tend to be people who you're going to be likely doing aerosol generating procedures anyway on soon anyway. And therefore it's worth being in that high level protection ready for that. Okay. If we look at tier two, we talked about already. Now, just to kind of clarify what an N95 and P2 mask is, they're the same thing. They're just different classification systems. The P2 is a European classification system. The N95 is a US classification system, and they basically mean that you have covered 95%. There's basically, I think, 95% filtration of all airborne particles if it's working well and fit checked, etc. And that's another kind of debate. So aerosol generating events, these are from the Safe Airway Society guidelines, and they show you that just coughing and sneezing technically is an aerosol generating event, but so is all these other things. So NIV, so any positive pressure. So NIV or positive pressure using a BVM, high flow nasal oxygen, some debate about how bad that is. any nebulizer, some debate about that too. So nebulizing salbutamol, adrenaline, whatever, CPR, tracheal suction, and then, laryngoscopy, tracheal intubation, and cricothyrotomy. These are all, they've classed as procedures vulnerable to aerosol generation, that if you do them very, very carefully with the right steps and processes, you might not get any aerosol generation, but with anything going wrong, or if you add in any of the things above it, the aerosol generating events, then you'll get significant aerosol generation. So these are the things we're talking about when we talk about AGPs, aerosol generating procedures or events. Now, so we talked about tier 1, we talked about tier 2, going from droplet to airborne because of aerosol generating procedures. And now tier 3 is what is kind of unofficial, because it's being instituted at many centers, many hospitals, many health services are bringing in a third tier. But it's not in official guidelines. If you look in kind of, Australian guidelines and Department of Health guidelines about PPE, they just talk about tier 1 and tier 2. And to be honest, tier 1 and tier 2 is satisfactory for almost all situations. But the reason for tier 3 is that there are some AGPs, some aerosol generating events, that are even higher than the average. And from an ED perspective, that's intubation, where, you're right there over someone's mouth, doing all sorts of aerosol generating procedures. And from our data, from SARS, a lot, loads of people who did intubations got SARS. And so that's like another level of risk. And because of that, a lot of centers are taking extra steps when you're doing these highest level AGPs, which from an ED perspective is pretty much intubation. And those are things like just having more body coverage, and taking other steps to minimize airborne risk. So I'm going to show you a few of these different things. So in the tier 1 and tier 2, technically it doesn't matter whether you wear any goggles, any form of goggles for your eyes, or a face shield. Either one is recommended. You can choose whichever one you think is best, but either one is recommended as part of tier 1 and tier 2 precautions. Whereas if you're being the person who's intubating somebody, a lot of people would prefer to have goggles that completely seal around the eye, so there's no airflow coming in, as well as a face shield. Some people are wearing full body suits, so covering the entire body, neck, and most of their face, and with the rest of their face covered by their goggles and their face mask. Some people are just adding extra hoods or hair covering. Some people are actually switching out the N95 with proper N100, fully enclosed respirators. Some people are using what's called PAPR, so powered air purifying respirators. And that's basically, kind of a hood, like it covers your head, and it's a powered version, I suppose, of an N95 or N100, and it's meant to be, better, but there's a lot of dispute about whether it is any better. And then there's other kind of devices. Some people have these special, just these kind of hoods that go over their heads with oxygen or air coming into it, blowing air into it, causing positive pressure around your face to make it less likely for aerosols to come up. And then other steps are things like taking post-procedure disinfection procedures. So like afterwards, using chlorine baths or alcohol baths to clean equipment, to clean your shoes, staff having showers, staff changing out of their scrubs into new scrubs. So these are all things that people are trying at tier 3, and invariably, and it's different in every institution what people are doing, and none of these things are recommended per se in any of the official guidelines. But you will hear many of these things, so it's good to know where they fit in the hierarchy of PPE, and really, for the most part, only really required if you're going to be intubating. So PPE risks so some of the PPE risks are if you don't choose the right PPE, obviously. So if you have an aerosol generating procedure and you don't use an N95 and you're not using tier 2, and if you are not properly, if anyone's got any questions, just maybe jot them down to yourself, and I'll give you a step to ask questions in a second. So not properly choosing the right PPE, or not wearing it properly and putting it on properly. And we're going to go through PPE in a second. And not using it properly. So touching and adjusting the mask, you're not really ever meant to touch your mask. If you do touch your mask, it's only meant to be the very edges, but really you're not meant to touch it at all. You're only meant to touch the strings, and ideally not to touch nothing at all with contaminated hands. And the problem is, a lot of that's unconscious. A lot of us do it unconsciously, and it's kind of a lot of practice and training to try and not make it unconscious. But it can be tricky not to touch your mask. Having said that, some people find that wearing a mask makes them less likely to touch their face, because the first time they touch, they go, oh, that's right, I'm wearing a mask, and then stop touching their face, which is what we do all the time. So touching your mask is a big problem. Taking your mask off, so frequently people are kind of pulling the mask down to have a breather or whatever reason, and then they're putting it back on. As soon as you remove it from your face, that mask has to go. So you're meant to take it off and discard it straight away. You can never replace it. Without it being re-sterilized, if you're doing that, which we're not currently re-sterilizing. And then the other thing is, but not removing relevant items between patients. So there is a kind of balance between the perfect scenario of taking everything off and changing it to the next patient versus having to actually conserve your PPE. And we'll talk a little bit about conservation of PPE in a tick. And we'll talk about it now, right? There's the idea that we'd all love to do the very best with PPE and be able to change everything between patients and all of us use N95s instead of surgical masks, etc. And that all sounds great, except if we run out of PPE, then the people who suffer are us, the same people, right? So if we're using the wrong PPE or too much PPE when we don't need it for low-risk patients, if we have another spike in COVID in 2 months, and we've run out of PPE because we wasted it all, then we're the people who will get COVID and we're the people who might die, right? So we're harming ourselves by not using PPE carefully and judiciously. So in a perfect world, we'd have unlimited PPE, but we don't live in that world. So we all have to be judicious with our PPE use so that we don't put ourselves at risk, in a month's time. So in terms of removing items, what a lot of people are doing, if you've got COVID areas, so if you've got a COVID area where you've got, this is our dirty area, this is our clean area, people are doing things like, so there's various options, but the mask generally stays on for often your whole shift in that area, or until you get a meal break or toilet break, and then you have to replace your mask. And your gloves come off with it. So between every patient, your gloves come off, your gown would come off, but your mask would stay on. And depending on your face shield or goggles, they can stay on as well, potentially. But what a lot of places are doing now is that they are, will have, say, a full-length gown, all arms and everything. And then between patients, they'll put an additional apron, plastic apron on top of that. They'll glove or double glove. They will have some sort of face or goggles, and their mask. And between patients, they'll just take off the eye protection, clean that or replace that, and take off the apron between patients, but leave the underlying gown and the underlying mask on through all your patients, because to conserve PPE and basically conserve PPE. So every kind of system is coming up with a different way of trying to conserve PPE in that way. But key things that are touching the patients, like your initial apron or gown that's touching them, or your gloves, have to be taken off between patients with appropriate hygiene and hand hygiene. So these are the guidelines generally accepted, and also in the WA PPE guidelines about when to change your mask as a minimum. And if it gets saturated and wet with your own perspiration, so as soon as it gets wet, it's out of here. If it gets soiled with body fluids, it's out of here. If it gets contaminated by patients coughing or something, it's out of here. If you wore it during an aerosol generating procedure, you must change everything between that and going to your clean area to your next patient. What I was talking about retaining some of it, like mask, is in your non-aerosol generating procedures, your routine care of patients. And if the mask has been obviously touched or manipulated by you, which I told you is a no-no, you've got to change it. So some of the common questions that come up with PPE, some people kind of would like to wear a mask all the time, even not in their COVID area, in their clean area, right? And when, as I said, if COVID becomes endemic in your community, which hopefully won't happen in WA because we're doing such a good job of crushing it, then that might be something we all have to do, is wear a surgical mask for all our patients, because we can't be sure that they might be coming in with a sprained ankle but actually have COVID. But while it's low level, the risk is so low together with our screen. So low level prevalence, and then we screen at triage. So the risk of someone slipping through this crack is so low that the benefit of you wearing that mask is very, very low. And and we're going to waste PPE. And then, as I said, when we get to the point that we need that mask, we won't have it. So I think that's the thing we've got to consider is just the baseline prevalence. And that's why we've got to follow local guidelines to some extent about where we're at as to whether that's necessary. And right now, it just doesn't appear to be necessary. Can you bring your own PPE is a common question. And that's a hard question to answer. Basically, all the hospitals and health systems say no, because they can't be sure that it's up to standard, that you might get sick. The other thing is that they can't be sure that you've properly sterilized or are properly sterilizing it, and therefore can expose other staff members to the germs that are on it that you haven't sterilized. But there are instances that people are using their own PPE. I know of, in terms of kind of goggles and other things, and that's it's a kind of big debate right now. If you're doing if you're someone who does intubation, and you want to talk about PPE more, we'll do that. We'll have a chat at the end of this session. Stay on the line when everyone else goes, and we can chat about that. But most people here aren't going to be intubating, so I don't want to spend too much time about that. So on the PPE topic, this is a good time for some questions. I think I've got no more PPE slides. Yeah. So I'll just stop the share. And does anyone have any questions? Let me just see. Okay, I've got a written question from Steph Ewan. Yeah, this is a good question. Coughing is listed as an aerosol generating procedure on the slide. Wouldn't this mean nearly every patient with respiratory symptoms require, tier 2 PPE? It's a very good question, and we'll kind of cover that in the next little bit of evidence. But even though coughing is a aerosol generating procedure, number one, we have to put a surgical mask on every patient with respiratory infection symptoms who comes into the department. So that heavily minimizes anything that spreads. So even if it aerosol generates, it usually just hits their mask and doesn't go any further. And generally with coughing, it doesn't tend to be that aerosols go that far. And that's a lot of why we have these kind of 1.5 meter rules, although that's not a perfect distance. So in theory, coughing would mean that they all need to wear N95s, but in practice, it doesn't seem to make any difference. And I'm going to talk about a paper in a second to demonstrate why it doesn't seem to make any difference in routine care. Any other questions? So if you can write them in or raise your hand now about PPE. You can either write the question in the chat or you can raise your hand and ask it in audio. I can't see any other questions. So I'm going to continue on. And after this study, we're going to do a PPE demonstration. Right, the N95 versus the P2, sorry, N95 P2, same thing, versus the surgical mask, right? This study was a landmark study that came out last year that I think it's really important everyone knows this information because it kind of really gives you a lot of confidence as a provider is why we're just wearing a surgical mask for routine care. And now those guidelines were around before the study came in, but the study has kind of cemented that as being all we need. So what they did, and this is not about COVID, obviously, because COVID just started, right? So it's about influenza, but that's another droplet spread virus, respiratory virus. And for the most part, droplet and aerosol spread seems to be the same between respiratory viruses. There's debates about what is droplet and aerosol spread and whether there are aspects of aerosol spread with all these viruses. But for the most part, we think they're mostly droplet spread and that the difference between an N95 and a surgical mask isn't much. So what did they do in this study? They got like 7 different health centers and that included emergency departments, but also outpatient settings like general practice and urgent care. And they randomized them. They clustered randomized people for a season of like 4 months of winter. They would just wear surgical masks in that place, and in the other place they randomized them to N95 masks, and then in another place to surgical masks, and then to randomize through all these centers to different masks, and they wore them for the entire winter whenever they were within 2 meters, 6 feet of a patient, right? And then the next year they would switch and they'd use different masks, right? So it was a really good kind of randomization trial to see what people are using, for these, like it was a real world setting. And so they instructed the wearers to wear the mask whenever they're within 6 feet, and did this for kind of 3 month periods, so 4 years of winters. And what do they find? the outcomes were kind of self-reported symptoms, and then they would take a swab for the influenza-like illness viruses, and they would also take kind of random swabs as well. And then they would, the primary outcome was about influenza detection on the swabs, or a rise in your serological titers. Now, they had a lot of people, so 2,800 unique participants, plus 1,400 who did it in more than 1 year. So overall, close to 5,000 healthcare practitioner seasons were analyzed, which is pretty large amount of data. And the bottom line is that the incidence of the flu in those healthcare workers was no different, right? And I mean, you might be looking at that saying, oh, it's even worse than the N95 group, but that's just standard, the p-value, that's just noise. Those are the same numbers. So basically, in a four-year trial on loads of healthcare workers for another droplet spread virus, that it didn't matter whether you wore an N95 or surgical mask. It made no difference in whether you got the flu or not for your entire, for those full 4 years. So that's pretty robust evidence that the N95 makes no difference at all in the routine care of patients in these settings. And then they had a meta-analysis that came out after this, which included this and some other studies, and found the same thing, that, when you add in all the other studies for another kind of 4,000 or 5,000 patients, N95s made no difference whatsoever. And the key limitations are that these were not inpatient settings, and it did include EDs, but there was also kind of urgent care and other outpatient settings. But for routine care, I think it's basically the same kind of exposures we're having, but it doesn't include obviously the critically unwell patients or patients that you're doing aerosol generating procedures. So people that you would normally use tier 2 stuff for, you should use tier 2 stuff for. But I kind of mentioned that study because I just think it's for me anyway, remarkably reassuring that I'm actually quite comfortable with the guidelines that for routine care of patients who might be coughing every now and then, I put a surgical mask on them, and I'm happy wearing a surgical mask and my eye protection and my gown and gloves. And they weren't even wearing all that stuff in these studies, but we're wearing even more stuff now. That a surgical mask is just fine. And have we done that same study in COVID? No. So it's extrapolated evidence. But it's for routine stuff. Be reassured you're fine. For aerosol generating procedures, another story. You need to upgrade. Now, I'm just going to see. Got chat here. I've got another question here about that. Is there any? Oh, hang on, I've got questions here. Yeah, so Caleb said this may not be applicable to COVID because COVID is more contagious. That is true, Caleb. It may not be applicable. That is one of the limitations. There is no paper on COVID, obviously, but we think that COVID is more contagious not because it's airborne. There's no evidence of that really at all, that it's truly airborne like chickenpox or measles or TB, which are truly airborne viruses. We think it's more contagious because it's quite contagious in the asymptomatic period. So my understanding is the current theories are that that's when it's more contagious. So the only way that would be a problem is if we had a high prevalence population and people were spreading it to us, who didn't have infection symptoms, and that's when you talk about whether we should be wearing masks, even surgical masks all the time, when we see all our patients, and that's when you'd have to switch. And the other question was, is there any relevant use of PPE in general practice, or just a mask to use? Well, I'm trying to think what you mean by that, but I would imagine that if you're seeing COVID patients or people suspected COVID patients, which often general practitioners aren't seeing because they're sending them to hospital, but then I would be using the same standards of PPE that we're using. So if it's routine care, which it almost certainly will be, I would be using all the PPE that I just mentioned in tier 1, which is surgical mask plus some sort of eye protection plus gown plus gloves. Now, I should put a caveat to that is there are some situations when you look at the ASIM guidelines that they wind it back a step and they go look for certain situations when you're quite far from the patient and maybe just chatting to them far away, you may just wear a mask and eye protection and not wear the whole, kit and caboodle. But in general, we would wear the cool kit and caboodle if we are, dealing with a patient in this setting, in anyone who's a query COVID patient. So but you know, and if you're doing that in GP, then I'd probably be wearing all that gear. But probably you're not doing that in GP because you often screen those people on the phone or at the door and sending them to hospital, I presume. And then another question: if someone comes in for COVID testing with only symptoms as sore throat, do healthcare workers need to wear all PPE or just surgical masks, gloves? I think I just answered that. I think I would be wearing all the PPE personally, because I don't see why you should be any less protected than I am when I see the same patient, or when my nurses see the same patient at the front door and swab them. And you know, you could choose to be if you want to be, but I wouldn't. So I think, you know, these PPE guidelines, you know, apply to basically all settings when you're seeing possible COVID patients. And so now, obviously, if we're getting very close to crushing COVID in our community, and we might get to a point that we might become a bit more relaxed about people seeing with sore throats or flu-like illnesses, etc. You know, and not wear the full PPE, but we're not there yet. Is my view. So yeah, so those are the only questions I had. So I'm going to proceed with. Oh no, we're going to talk about PPE now. Should we do some PPE? So we're going to actually stop the share, and we're going to go through the way we don and doff PPE. The vast majority of all healthcare worker infections happen because we don't don and doff PPE properly. And it's not easy. It's easy to make mistakes. This is one of the most important things that you can learn from this discussion. So we're going to actually focus on this because it's really important. And none of us are good at it, you know. And the problem is, because we're so short of PPE, we can't really practice with PPE normally. So the only time you get to practice is in the real time when you put your PPE on. And that's why it's good to have a buddy system where somebody can see you putting it on and off and talking through it with you and making sure you're doing it properly, so you're getting kind of observed and trained on the spot. So let's close that. All right. So generally, if you're going to be doing PPE, you need to have posters. Because if you don't have posters, you just won't do this properly. None of us can remember this stuff properly, and you need to be able to go through it properly. So I'll hand over to our PPE people, Gavin and Anna. This is Gavin, and our GP anesthetist, and this is Anna, also one of our other patients, and Fiona, one of our other nurses. So go through.
Okay, so again, we've got a patient in the negative pressure room. We're going to be intubating that patient. Have you put your PPE on, and I'll be your post-study chair.
Thanks very much. I'm going to start with my hand hygiene. I'm going to try and follow because I get a bit nervous at times, and I like to follow the chart.
That looks like it's the right size for you, Gav. Yes. Around, make sure that your back is covered. So this one ties up. And do a Velcro. Your back's quite exposed, Gav. We're just going to make sure that you're covered up.
Now, just about the ties, the bottom tie needs to be at your side so that you can untie it easily, yeah? Not at your back. And the top tie is a bit of a problem because the Velcro is ideal because it comes off easily. But some people either don't tie the top or tie it quite loosely because they really need to be able to remove that and just pull it off, ideally, without putting their hands behind themselves. Did you do anything? Sorry. Oh no, it's just actually this is Donny's fine. You don't do it.
Doffing. Airborne PPE with the N95.
So this is tier 2 PPE we're doing now, airborne protection for aerosol generating procedures.
Okay. Well, that was pretty good, Gav. Yeah, so
squeeze
the
that
fit check.
You squeeze that down.
Yeah.
So he's doing a fit check, which means he's just breathing normally in and out. And can you see, I don't know if you can see it well from there, but you can see, you need to be able to see that the mask is coming in and out when he's breathing in and out. If it's not drawing in when you're breathing in, you have not passed your fit check. You do not enter the room, and you need to either refit it, get another size mask. And if you can't get that person to pass their fit check, then they do not enter the room. The other thing is with expiration, you should put your hands around the areas of the mask and make sure you can't feel any air around your mask coming out of it. So it's inspiration, seeing the mask move, and expiration, making sure you can't feel any air leaving.
So I think I'm going to wear
I'll just put the
face mask, eye shield on. Normally wear glasses, don't you, Gav?
Yeah.
So glasses
just a facial for now, Gavin.
Yeah, and then we've got the full face shield going on. Feels comfortable. And then lastly, Gav, it's your gloves.
So for normal PPE, single gloving is fine. For aerosol generating procedures, people like intubation, they'll often double glove.
Ensure that your wrists are covered, Gav.
Gloves, I think.
Yeah, we'll just do single gloves.
For the purpose of this, we'll just do single gloves.
We go. Turn around, Gav. Yeah. Oh, this is a bit exposed. This gown is a bit small for you.
We'll get a bigger gown for Gav next time.
Yeah, yeah. Okay, I think you're ready to go in, Gav. Yeah.
Okay, great. So that's the donning process of PPE. I'll just see, does anyone have any questions about the donning process about PPE before we do doffing? Oh yeah, right. So one question is about any reason using chemotherapy gloves. Just what we had available to do the sim. So,
Yeah, that was all.
Yeah, just all we had available to do the sim. No reason to use the chemotherapy gloves. There are some services that are using kind of one set of gloves, and then if they're double gloving, they're using a different set of gloves, and the first set of gloves is a bit longer, and sometimes they're borrowing things like chemotherapy gloves, but there's no real reason for that, that you need that. But the other thing is, the second question is why double glove? So there's kind of a few reasons, but the main reason is when people are doffing and you've just done intubation, you remove the outer. Normally, you remove your gloves and then you do everything else, right? In the doffing, like remove gloves first. But what they're doing is they're removing the outer gloves first, doing hand hygiene or glove hygiene, and then using those other gloves to do the inner gloves, which are cleaner, to help remove all the rest of their PPE before removing those finally at the end and hand hygiene again. And the reason for that is they're having something that's they think relatively clean while they're touching all these other places, rather than using their hand to touch all these other places and getting more COVID on their hands. That's one theory as to why people are double gloving, and the need is double gloving when they're doing these procedures, so that they can remove the rest of their PPE, not with their hands, but with gloves, with clean gloves on. But, these are all, that's a variation in protocol. The normal would be single gloves and removing your gloves at the beginning. Okay, so we'll do doffing now?
Yeah, so let's do doffing.
Cool.
Okay, so go, use your poster.
First, touch inside.
So that was the outside. Can you do the outside?
Oh, sorry.
Yeah. So the first glove you remove, because you're using a glove to do it, which is dirty, you grab the outside of your glove to remove the glove.
And then the inside.
For the second glove, now using your hand, which is clean, you can go to the inside and touch the inside of the glove to remove it.
And into
Yeah.
Black bin.
And whatever bin you're using for doffing needs to be big and easy to put stuff into, and you shouldn't have anyone having to push stuff down. So as soon as it's getting to a level where it's getting semi-full, it needs to be empty.
Okay, so you can remove your gown now.
So hand hygiene follows every step in doffing.
So you've got to reach behind.
Yeah, so this is, so are you able to pull that off without reaching behind? Yeah.
This actually instructs you.
Reach behind, yeah. This is not ideal. But yeah, so I mean, here Gab's got to reach behind and untie, which is not ideal. That's why gloves that have Velcro, you can actually just pull them off here without having to put your hands behind and touch the back of your neck and things. He's keeping his hands on the inside now of the gown. And then just drop it in, I think. Great. Good. Happy with that, buddy?
Yeah. Yes, that was perfect. Okay, hand hygiene. Now you're going to be removing your face visor. That would go into the bin as well.
Some places are reusing these visors, so they get clean with a special sterilising liquid wipe.
On hand hygiene again. And lastly, Gab, you're going to be removing your mask. Bringing those elastic bands over the top of your head, being very careful that you don't touch the mask. Your glasses actually probably need to come off first.
Yeah, your glasses will have to come off first.
Your glasses need to come off first.
Yeah, so unfortunately, glasses aren't on the paper poster. So, yeah, and that's a complication to the system, that the glasses have to come on after the mask and go off before the mask comes off. So theoretically, probably if you're taking glasses off, I would hand hygiene again after doing the glasses and then do the mask. And then she's only touching the straps, never touches the mask, and we'll drop it in. Yeah. All right.
Okay.
So that is donning and doffing of PPE.